Retinoblastoma. Recognize the features early and save a child's life. Retinoblastoma is the most common primary intraocular malignancy of childhood. Worldwide, it is estimated that 8,000 children develop retinoblastoma and 3,400 die from retinoblastoma annually. Most deaths occur in developing areas due to delayed diagnosis and delayed treatment. In this video, we discuss the various presentations of retinoblastoma, differential diagnosis, and treatment modalities. About 2/3 cases of retinoblastoma are unilateral, and 1/3 are bilateral. The most common presenting feature of retinoblastoma is a white pupillary reflex, or leukocoria, which is seen in about 60% of cases. This white pupillary reflex is a result of reflection of light from the white mass in the retrolental area. The second most common presenting feature is strabismus, which occurs in approximately 20% of cases. The other less common features of retinoblastoma include pseudohypopyon, hyphema, heterochromia, unilateral mydriasis, red painful eye, proptosis, and orbital cellulitis. Clinically, retinoblastoma begins as a small transparent lesion in the sensory retina. As the tumor enlarges, it becomes opaque white and develops a dilated retinal feeding artery and draining vein. Retinoblastoma can be classified based on the International Classification of Retinoblastoma into 5 groups. Group A includes small tumors, less than 3 millimeters in size and located outside the macular region. Group B includes larger tumors, greater than 3 millimeters, or tumors located in the macula, or tumors with associated subretinal fluid. Group C includes tumors associated with localized subretinal or vitreous seeds. Group D includes tumors associated with diffuse subretinal or vitreous seeds. Group E includes extensive retinoblastoma occupying over 50% of the globe, or diffuse infiltrating retinoblastoma, or those with neovascular glaucoma, anterior segment involvement, or opaque media due to hemorrhage in the anterior chamber, vitreous, or subretinal space. A number of ocular disorders in infants and children can clinically resemble retinoblastoma. Pseudoretinoblastomas include persistent hyperplastic primary vitreous, Coats disease, ocular toxocariasis, endogenous endophthalmitis, astrocytic hamartoma, medulloepithelioma, congenital cataract, morning glory disc anomaly, combined hamartoma, incontinentia pigmenti and other exudative retinopathies, congenital retinochoroidal coloboma, and many others. The primary goal of management of retinoblastoma is to save life. The secondary goal is to save the eye, and the tertiary goal is to save vision. Various treatment modalities are being successfully used for retinoblastoma. There are local treatment modalities that can be used to treat small tumors measuring up to 4 millimeters in basal diameter and 2 to 3 millimeters in thickness. These local treatment measures include cryotherapy, which can be used to treat small peripheral and equatorial tumors. They also include transpupillary thermotherapy, which is useful for small tumors located posterior to the equator. Additionally, laser photocoagulation can be used to delimit the tumor and coagulate the blood supply of small tumors located posterior to the equator. There are also chemotherapeutic measures that can be used to treat retinoblastoma, and these have been divided into local chemotherapy and systemic chemotherapy. The local methods of chemotherapy include subtenon's carboplatin and intravitreal methotrexate for vitreous seeds. Another local form of chemotherapy includes intra-arterial chemotherapy, using intra-arterial melphalan for targeted drug delivery to the tumor. The systemic methods of chemotherapy delivery, with 6 cycles of intravenous vincristine, etoposide, and carboplatin, is used for chemoreduction or post-enucleation adjuvant chemotherapy in high-risk retinoblastoma. Methods of radiation therapy for retinoblastoma include plaque brachytherapy, external beam radiotherapy, and proton beam radiotherapy. Plaque brachytherapy employs a dose of 40 Gray or 4,000 centigrade to the tumor apex and is useful to treat tumor recurrence following chemoreduction. External beam radiotherapy and proton beam radiotherapy are useful for extraocular retinoblastoma and in cases of extensive intraocular tumor recurrence post-chemotherapy. Lastly, there are surgical methods for treatment of retinoblastoma, and these include enucleation and exeneration. Enucleation is used for advanced intraocular retinoblastoma or those eyes that appear to be high-risk retinoblastoma. Exeneration is employed for those with orbital invasion. Histopathologically, retinoblastoma is composed of areas of basophilic viable tumor and eosinophilic necrotic tumor, which may contain purple foci of calcification. Viable tumor appears basophilic because it is composed of poorly differentiated neuroblastic cells that have large hyperchromatic nuclei and scanty cytoplasm. Many mitoses and apoptotic cells are present. Viable tumor typically forms perivascular sleeves and cuffs. Increasing degrees of tumor differentiation are evident as Homer-Wright rosettes, neuroblastic differentiation, Flexner-Wintersteiner rosettes, which represents early retinal differentiation, and florets, which represents photoreceptor differentiation. High-risk histopathologic features of retinoblastoma include anterior chamber seeding, massive, that is greater than 3 millimeters, choroidal invasion, retrolaminar optic nerve invasion, and any combination of choroidal and optic nerve invasion. The true success of retinoblastoma depends upon early diagnosis and prompt treatment, which can only be achieved by early recognition of symptoms by the family and timely referral by the healthcare personnel.